To conclude the session on meeting the experts on lung cancer is the lecture on lung cancer prevention in Asia. And to introduce the lecturer, may we call on Dr. Gerardo Cornelio, the director of the Cancer Institute of St. Luke's Medical Center Global City. Dr. Cornelio is also the chairman of Department of Medicine at the San Juan de Dios Hospital. At the same time, he is a clinical associate professor of medicine at the University of the Philippines, Philippine General Hospital. He was the past president of the Philippine Society of Medical Oncology. Dr. Cornelio is a fellow of the following medical societies: the Philippine College of Physicians, the Philippine Society of Medical Oncology, and the Philippine Society of Oncologists. He is a diplomate of the Philippine Specialty Board of Internal Medicine and is an active member of the following international organizations: the American Society of Clinical Oncology, the Internal Association for the Study of Lung Cancer, and the European Society of Medical Oncology. May we call on Dr. Gerardo Cornelio to chair the last lecture of the day.
Good evening, ladies and gentlemen. Dear colleagues, I'm Dr. Gerardo Cornelio. I'm a medical oncologist, and I work at the University of the Philippines, Philippine General Hospital, and St. Luke's Medical Center Global City. Our last speaker is an awardee of the International Association for the Study of Lung Cancer Merit Award in the Women for Oncology Award, Professor Emeritus Sumitra Thongprasert. MD is from the Chiang Mai University. She is a senior consultant in oncology in Bangkok Hospital, Chiang Mai, and the director of the Hospital Center of Excellence in Cancer. The IASLC Merit Award was given to her to honor her extraordinary contributions to the IASLC's development and her initiation and development of the Asia Pacific Lung Cancer Conference, or APLCC, and committee within the IASLC. Her research interests include lung cancer quality of life, chemotherapy and targeted therapy for lung cancer, and biliary tract cancer. She was given the Women for Oncology Award for ESMO for significantly supporting women in oncology. She chaired IASLC's Education Committee from 2010 to 2014 and served on the IASLC Board of Directors from 2011 to 2015. She is a founding member of the Thai Society of Clinical Oncology, as well as the Asia Pacific Lung Cancer Group and the Asia Pacific Lung Cancer Conference, which is a biennial event hosted by the IASLC, TSCO, Chiang Mai Lung Cancer Group, Faculty of Medicine at Chiang Mai University, and local organizing committee. Let us all listen to her very relevant lecture on lung cancer prevention in Asia. Ladies and gentlemen, dear colleagues, let us welcome Professor Emeritus Sumitra Thongprasert.
Hi, thank you very much for joining this session. Today, my task is to tell you about the low-dose CT screening for lung cancer in Asia. My co-author today is Dr. Nataya Taipuride from Julapon Royal Academy, Bangkok, Thailand. We have no disclosure. Outline of the talk for today, we would like to present to you the lung cancer in Asia, the timeline of low-dose CT screening for lung cancer in Asia, the summary of study that had been done for lung cancer in Asia, and also the current guideline for screening of Asian lung cancer. As all of us know, lung cancer remains the leading cause of cancer incidence and mortality worldwide, especially in Asia. Approximately 60% of the world's new lung cancer cases and also death rate predicted occur in Asia. Over 1/3 of these will occur in China and also in Asia proper. Tobacco smoking is a major risk factor for lung cancer, particularly in men, and causes nearly 80% of male and 50% of female lung cancer death. As you can see, besides tobacco smoking, you also have several factors related to lung cancer. Environmental, especially particulate matter, occupational exposure, indoor air pollution, radon, secondhand smoke, genetic factor, and etc. In male population, the incidence of lung cancer is quite high, especially the prevalence of smoking rate is corresponding to the lung cancer incidence. Female, as you can see, in Asia, women compared to women in Western countries with similar lung cancer incidence rate. However, as all of us know, smoking rate in Asian women are low, particularly in China. However, the incidence in female lung cancer is not that low. So this is one of the prevalent occurrence tobacco smoking in female. Genetic and environmental factors play a role in lung cancer in never smokers. So, low-dose CT screening for lung cancer study in Asia, as you can see from systemic review, 25 studies from 6 countries were identified: Japan, China, Taiwan, Israel, Korea, India, and Thailand. All these countries start screening at several time points. The first one is 1993, which occurred in Japan, ALCA project. 1994, the low-dose CT study in Shanghai, in China. 1998, in Jerusalem. In 1999, in Seoul. 2004 in India, 2007 in Taiwan, 2012 in Thailand, and 2014, etc. You can see that besides local study in each country in Asia, there are cooperative studies with international, such as Jerusalem International LCAP program, the Nagano ILCAP, the Shanghai and Beijing ILCAP, and etc. So this is the landmark of the low-dose lung cancer screening in each country in Asia. The screening guidelines were particularly different. Japanese has their own guideline, several other countries, China, Korean. So we have summary. The screening study enrolled various participants. This is from 25 studies altogether. 17 studies were done in asymptomatic adults. 3 studies were in smoker. 1 is in family history of lung cancer. And also 4 studies that had different risk allocation: occupational exposure, cooking fume exposure, passive smoker, history of COPD, pulmonary fibrosis, or pulmonary tuberculosis, and also a family history of lung cancer. In summary, the baseline lung cancer detection rate ranged from 0.2 to 2.9%, depending on the risk characteristic of the participant, slight thickness of low-dose CT, the NODU protocol and its management. Lung cancer detection rate over 1% were observed in individuals with indoor air pollution exposure, lung cancer family, which is around 1.7%, smoker at 1.4%. There are several ongoing large-scale national lung cancer screening trials in Eastern Asia to evaluate the efficacy of low-dose screening for never and light smoking, such as in Japan, China, and also in Taiwan. Because as all of you know, in this country, women who had never smoked or light smoker achieve high incidence of lung cancer with EGFR mutation. The feasibility of conducting population-based low-dose CT screening were done in China and also in Korea. Develop a web-based network system was also presented in China and Korea. And risk prediction model for lung cancer were done in China, Korea, and Taiwan. Summary of National Low-Dose CT Screening Guideline for Lung Cancer in Asia. Most of the guidelines were in Japan, Korea, China. 2013, Japan allocated patients who are over age of 50, smoking more than 30 packs a year, and quit time in ex-smoker was not available. Korea assigned people who are 55 to 74 and smoking more than 30 packs a year and quit more than 15 years. China, 50 to 74, smoking more than 20 pack years and quit more than 5 years. This is a difference in each country based on their local guideline. In Thailand, we don't have any guideline for low-dose CT scan yet. However, there are several private hospitals provide the low-dose CT screening for all comers. In Saudi Arabia in 2018, it was not recommended that a national screening program be implemented for lung cancer at this stage. In Asia, the low-dose CT screening for lung cancer could yield high number of lung cancer and early stage detection rate, not only in the high-risk smoker and even also in never smoker with other risk factors. Low-dose CT screening also beneficial in countries with previously reported low and moderate lung cancer incidence and smoking prevalence as India, Thailand, and also Israel. So low-dose CT screening in developing countries in Asia is challenging. The high-risk incidence in individuals with tobacco smoking and environmental risk exposure. However, the screening depends on the resources allocated by the government and healthcare infrastructure. Tobacco control and smoking cessation policy should be the most important national priority for reducing the burden of lung cancer and other smoking-related disease, together with raising awareness of smoking and environmental risks. I would like to call your attention that at the time of COVID period, the difficulty of healthcare system, including lung cancer screening, is much more difficult. However, as a healthcare provider, we should care for early detection of lung cancer. Thank you very much for your attention.
Good evening, everyone. From Manila, Philippines. It is an honor for me to be chairing this excellent presentations that have been given to us by excellent speakers. Now, we have 15 minutes for this presentation, for this question and answer. So I'll go on with the presentations, but first allow me to thank our excellent speakers, Dr. Alex Dillon from Memorial Sloan Kettering in New York, Dr. Stephen Liu from Georgetown in Washington, and Dr. Ang Su Fan, Dr. John Wencheng Chang, and Dr. Sumitra Thongprasert. First of all, allow me to ask questions for Dr. Stephen Liu, asked by one of our attendees. What is your experience in giving IO in patients with active brain metastases, considering its toxicities as well as causing cerebral edema?
Yeah, it's a good question. I haven't noticed a lot of issues. I feel fairly safe giving them. We know that the response rate in non-small cell lung cancer is about 30% for people with untreated brain metastases. We don't know the response rate in small cell. As for the registration studies in Empower 133, those brain metastases need to be treated before enrollment. However, in my own personal experience, we do see responses that's probably from the chemotherapy. I've not seen issues with toxicities. I've not seen increased rates of radiation necrosis or problems with edema. After I complete induction chemoimmunotherapy for small cell, I often then move to radiation into the existing brain metastases just to prevent further progression in the future. But I have not seen any safety concerns myself.
Great. What do you offer your patients in second line small cell lung cancer after the Empower 133 and the Caspian trials?
So after starting with chemoimmunotherapy, the standard options here would be lurbinectedin or topotecan. I'm comfortable with either. My own practice standard of care would be lurbinectedin, though it's clearly an area where we need better drugs, and there are a lot of interesting trials, many of which we have open here. So I always try to have a clinical trial available. Outside of a trial, I think the standard would be lurbinectedin for us.
Thank you. For Dr. Ang Su Fan, where do you see the use of IO and IO combination or IO monotherapy? What factors do you consider in deciding to go with either combination or monotherapy?
Okay, so for IO single agent, we should only consider use this for PD-L1 more than 50%. Right. So and then the question is whether you should give IO alone or IO chemotherapy. So from the previous a few studies, we noticed that women and those never they do not benefit that much from IO single agent. So I think in this subgroup of population, and as well as for those maybe with low tumor mutational burden, these are the group of patients we may not want to use IO alone, although their PD-L1 is more than 50%. Right? For those with PD-L1 less than 50%, right? So we must always combine IO with chemotherapy and not just IO alone.
Thank you. How do you decide in which IO agent in this era of different, we have a lot of IO agents now. Which IO agent do you particularly use or offer for your patients?
Well, I think there is no direct comparison between various IO, head-to-head comparison. I guess eventually we have to follow the trial regimens as well as the local approval. And for example, when you want to use pembro for non-small cell, you have to for non-squamous cell, you have to combine it pemetrexed with carboplatin. Right, if you want to use atezo, you have to combine with this bevacizumab, paclitaxel, and carbo. Right, so I think the Empower 132, this atezo plus pemetrexed with carbo. I think this study, this regimen was only approved for the use in Japan and not somewhere else, right? So eventually we have to follow what are approved locally.
Do you still need the use of PD-L1 testing based on your lecture?
Yes. I always insist to have a PD-L1 tested. The reason is very simple. There's the saying, know your enemies, right? So that you don't lose a battle, right? So by knowing PD-L1, we know how good our weapons are, how long they may work, right? And then by knowing this, right, we can roughly estimate where we are and where our NAB is, So unless for some reason that we couldn't get that it tested because of insufficient tissue, because patient refused to rebiopsy. Beside this reason, I see no reason that we must not do PD-L1. I insist a PD-L1 test to be done.
Thank you. For Dr. John Chang, If you do sequential TKI, would it be a big risk for our patients in developing, brain metastases, considering the fact that osimertinib has shown big data on this particular group of patients?
Yes, the third generation TKI, such as osimertinib, do benefit the CNS metastasis in view of the good penetration and the lower IC50. However, the second generations also benefit from the brain metastasis in cases who had had the previous brain metastasis or who did not have brain metastasis. Although the preclinical data demonstrated that the third generation is benefit more, the CNS concentration, CNS penetration rate is higher, but in patients with brain metastasis, the second generation also benefit then as compared to the first generation. So I think the second generation also has benefit on the brain metastasis in cases who had brain metastasis or who had not brain metastasis.
Okay, thank you very much. Okay, there's another question here. The immunotherapy studies on small cell lung cancer appear very underwhelming, leaving questions about how clinically significant the benefits are. What other biological processes do you think may serve as better targets for treatment for small cell lung cancer? I think this is for Dr. Liu.
Yes, I mean that's the issue. Is there have been over dozens of failed phase 3 trials, and I know that the results are not as big as you wanted. I know that I'm not showing you a hazard ratio of 0.1, but remember that this is the first trial in 40 years that's shown any difference in survival. So, yeah, I don't know that I would use the word underwhelming. There's certainly room for improvement, and there are really two strategies to do that. One is to go bigger, using larger studies with more immunomodulatory agents. We're seeing that with some PARP inhibitor trials. We're seeing that with new anti-TIGIT molecules. But the other is to go smaller. That's going to be the long-term solution, where we try to subdivide small cell into different subsets and target these unique specific processes. But biomarker studies in small cell lung cancer are extremely difficult. And so certainly room for improvement, but it's an important first step. Right now, we don't have those biomarkers, but there are a lot of interesting studies underway now.
What do you think for patients who are not candidates for immunotherapy, for example, in first line, for some reason they have contraindications? How did you move from first line to second line? Of course, using platinum and etoposide. What would would you still use lurbinectedin, topotecan, or would you?
The options are very limited, right? And so you're talking about just cytotoxic, where survival is not very impressive at all. And with the addition of immunotherapy, we see a modest improvement in survival, but that's if you're looking at the median. For a subset of patients, you will see long-term survival. And I have many patients in my clinic now alive years later that simply wouldn't have been alive with chemotherapy alone. And so it's not everybody, it's not the majority of patients, but it is some patients.
Thank you. For Dr. Sumitra, Fred, is additional sputum cytology useful for screening?
Well, not as a solo screening. However, it might be complement with the low-dose CT scan in order to exactly lead the physician to learn that this is cancer or not. So sputum cytology may come in after you find something else on low-dose CT scan. If you do sputum cytology upfront without CT scan, then you will have some difficulty finding where is the spot producing abnormal cytology.
Thank you. How would you see lung cancer screening in Asia in the next 5 years?
Well, at the present, most of the lung cancer screening were in the large countries like Japan, China, Taiwan. However, for Southeast Asian countries, we are still somewhat difficulty related to the fact of the cost of screening and also further assessment of the finding on the CT scan, which need proper adjustment regarding the type of investigation and several work to be taken care of. And also, you need to explain the importance of finding to the patient before you go in with the screening.
Thank you very much. I think we've covered much. Thank you very much for our speakers and for sharing your expertise with us here in Asia.
May I have a comment on the sputum cytology?
Yes,
Yes,
please.
Because
please.
in Taiwan, the Thailand trial doing the CT scan on those who do not smoke, but who had a family history of lung cancer and around 50 years old. But most of them, I mean, the majority of them are asymptomatic. And the lesions are quite small, and 97% of them are stage 1. And those are very limited, even less than 8 millimeter.
Yes.
So it is very unlikely to see any endobronchial lesion or even get the sputum or even a positive cytology test. So in our cases, it seems unlikely that the sputum cytology would add any benefit on the screening.
Okay.
Thank you.
You so much. Thank you. Thank you, everyone, for keeping on time.
Thank you.
Thank you.
Thanks.
Bye-bye.
Thanks a lot. Thanks,
Bye.
everyone. Bye.
Bye.